Okay, so to start, I want to acknowledge that the research that I'll discuss today was conducted on the traditional lands of the Australian Aboriginal Kulin Nations. And I also want to acknowledge the traditional use of plant medicines for ritual, ceremony, and healing purposes across the globe, and that this has contributed to the current wave of psychedelic research. So thank you for the introductory pun before. There are many puns in this topic, so thanks for joining me for a touchy talk. So I'll be speaking to you today about my PhD research, which is on participant experiences of therapeutic touch in the context of a clinical trial of psilocybin-assisted therapy for generalized anxiety disorder. So psychedelic experiences can be profoundly challenging, and we know that during acute effects, people's verbal capacities might be compromised. Also, the complexity of someone's internal experience might be very difficult to put into words. So from as early as the first wave of psychedelic research, researchers have used touch as a means by which to support patients who are having difficult experiences. However, there has been some controversy in this field, and there are documented instances of sexual misconduct, and I'd like to acknowledge the voices of people who have been harmed in this context. Those who were able to speak out have motivated me personally to conduct research in this space. Beyond these sort of major transgressions, other issues raised include problematic patient-therapist power dynamics, difficulties with consent while someone is under the influence of a drug, and particularly one that may enhance suggestibility, and patients experiencing touch as unpleasant or sexual or coercive, regardless of the underlying intentions for the provided touch. Advanced care directives have emerged as a potential harm reduction strategy to promote the appropriate use of touch in psychedelics. And this typically involves patients consenting to touch ahead of their dosing sessions. This is the paradigm that we have used in the research that I'll discuss today. And I'll touch a little bit more on the specifics later, but most importantly, we really should understand the function of therapeutic touch in order to inform whether it continues as standard practice in psychedelic-assisted therapy. So within this study, I'm exploring participant views about the importance of touch in psychedelic-assisted therapy, how and when touch might interact with the therapeutic relationship or process, and how patient attitudes towards touch evolve across treatment. Data collection is occurring in the context of the PSYGAD1 clinical trial that's currently underway at Monash University in Melbourne, Australia. So this is a phase 2 trial evaluating the safety and efficacy of psilocybin-assisted therapy for generalized anxiety disorder. At this stage, the majority of the trial's 72 participants have been enrolled, and I believe that the last participant should finish their treatment by the end of this year. This is a triple-blind, active, placebo-controlled trial with a diphenhydramine comparator. And the treatment involves 2 dosing sessions, which are inlaid with amongst 9 psychotherapy sessions. So for consenting participants, 3 qualitative interviews occur across the treatment. This research predominantly draws on the first 2, and these happen at baseline, so right before the first dose, and the second happens after the second dose, but before the full treatment has concluded. So within this trial, touch is allowed with specific guidelines for its use. Our advanced care directive means that touch is discussed, consented to, and practiced ahead of dosing sessions. This typically occurs around session 2 or 3 of preparation. There are mandatory limits and guidelines for the use of touch. So, for example, it's recommended that touch takes the form of a handhold or a touch on the shoulder, and that it is quite limited in nature. And it's mandatory that touch would not occur on certain areas of the body that might be considered like erogenous zones, and that it would never be sexual in nature. And we ask participants to take quite an active role in specifying their touch preferences. So this includes specifying whether one or both, or indeed no therapist provides touch, what form that touch would take. And in particular, we ask patients to specify who initiates that touch. So it might be that participants feel comfortable with a therapist noticing that the patient is experiencing distress and responding to that by offering to hold their hand. But some patients might not feel comfortable with this. And for this reason, we also allow participants to specify that touch will only occur if they initiate it themselves. And this whole process is supplemented by in-session consent, where participants can revoke their consent to touch at any time, but they cannot add to their pre-specified boundaries about touch after capsule administration. Over 90% of participants from the clinical trial have agreed to participate in the qualitative interviews, and I'm presenting today on 14 participants that have been analysed with 2 time points each. And the interviews are being thematically analysed according to the Brown and Clark model. This is a predominantly inductive approach following an iterative process, and we used some collaborative coding at the early stages to develop the major themes. So onto our preliminary results. These fell into 3 overarching themes, which included participant experiences and expectations of touch, the experienced function of therapeutic touch for participants, and some practical considerations for the delivery of therapeutic touch. So at baseline, the use of touch was generally positively evaluated by participants, with distress management forecast to be the main application. Participants felt that touch could be grounding or calming in moments of distress, and that's highlighted by this participant who says that they can imagine if they were feeling distressed that having that kind of grounding touch from someone could be really helpful for them in the moment to help calm down. Participants who described themselves as being less comfortable with touch occasionally cited difficult or confusing touch experiences during childhood. So this participant did consent to the use of touch, but they acknowledged that for them, it was more of an uncomfortable sort of scenario. And they go on to say that when you think about when you would typically have that type of touch, it would come from a mother comforting you or patting you on the back, and that her childhood was not like that. Other reasons that participants described for being hesitant to incorporate touch into their treatment included feeling that touch might be a sort of jarring sensory experience if it came suddenly. One participant described being quite hesitant around touch because she was concerned about having sweaty hands. So that sort of feeling of self-consciousness arising there. And others simply acknowledged that their underlying preferences around touch meant that they weren't a hugger and they weren't sure if this would be useful for them in this context. After experiencing the drug sessions, we found that many participants really emphasised the importance of touch during their dosing experience. And multiple participants stated that they wouldn't want to go through a psychedelic experience in this context without having touch available to them. So this participant describes how the use of therapeutic touch was a major part for them and that it was more important than they ever thought that it would be. Of those participants who did raise initial concerns or described themselves as less touch-oriented, the majority did go on to find touch very helpful in their therapy. So this participant describes their initial concerns around touch transforming and how actually in the end it was so fine that when the therapist went away, they could ask them to come back. Of note, some participants did not make use of touch during their sessions, and at least one participant didn't follow this trend. And they had kind of a positive or a neutral evaluation of touch, but said that ultimately, had it not occurred, it wouldn't have made such a difference in their treatment. The final element of this theme that is of most interest to us is the comparison between the psilocybin and the diphenhydramine conditions. There were some differences in the way that people responded to touch, which may be explained by experimental condition, but the unblinding won't occur until the end of the study, so you'll have to look out for the paper for that one. So onto the function. The way that touch was utilised by participants varied quite widely. So on the one hand, we did see touch predominantly being used during moments of distress. That included fear or loneliness, emotional overwhelm, or paranoia. However, touch was also used during moments of joy. And based on participant accounts, the role of touch in providing a sense of connection was really important to participants at both ends of this emotional spectrum. So this participant described an experience of paranoid ideation. The quote is a little bit unwieldy, but essentially he believed during this moment that the therapists were telling him that he was a monster, and that meant that the use of verbal support became almost irrelevant. But even though the therapists were telling him, yes, you're a monster, he was still able to connect with them through a group hug during this really frightening experience. And this participant describes an encounter during their dosing session with a mystical sort of being. So they described the clouds going past and the colours changing and it feeling like this being was playing with them and smiling and reaching out for their therapists during this moment because they wanted them to be a part of it. And on doing so, having a feeling of euphoria. And I suppose that these two accounts really exemplify the poles of experience and the role of touch in providing connection for participants. Many participants differentiated between the immersive inner world that they experienced with the eye shades and the headphones on, and contrasted this with taking these sort of sensory aids off. So they often called this going in as compared to coming out. And participants described strategically using touch to navigate these two states, and in particular to manage the distress or overwhelm that sometimes came with being in. And in this way, touch was sometimes able to facilitate participants staying in contact with that internal world and potentially staying longer or going deeper. So this participant describes exactly this. They say that having the therapeutic touch meant that they could stay in, but know that the other place existed. And this meant that they could still continue doing the work of the session, feeling safer and not having to choose between one or the other of these two worlds. Many participants reported that their experiences of touch had contributed towards broader therapeutic goals within their treatment. And it was apparent that participants really constructed the meaning and the purpose of touch in really nuanced ways that fit with their own idiosyncratic views of themselves, their histories, and their treatment goals. So we see this person describing touch as aligning with one of their intentions to be more open to help and care. And they say that practicing or embodying that intention for them meant asking for a hand to hold. And in fact, there were many participants that used therapeutic touch as an opportunity to engage with particularly interpersonal processes that they found personally challenging. So this included being open to help, letting go of perceived dysfunctional independence, or having a corrective touch experience where they felt that they had not had such good experiences within their history. So in terms of practical considerations, the therapeutic touch protocols that were used in this trial were generally evaluated really positively by participants. And participants endorsed finding our protocols and the implementation of therapeutic touch to be transparent and professional. And some participants highlighted that the consent process had really helped them to feel a sense of safety around the use of touch. So this participant described how the clarity around the way that the therapist spoke to them about consent, that clarity and transparency had made them feel really safe about it, and that the clear guidelines had been really helpful. The role of trust in the therapist-client relationship was emphasized by many participants as a really important ingredient in the delivery of therapeutic touch. And this interacted with both the presence of the dyad and with therapist gender. So we saw one participant who spoke about having the dyad there feeling like a really important safety consideration for them that might not be quite as relevant in the context of working with a therapist that you had been seeing for a long time. There was another participant who described initially consenting only to the female therapist providing touch, but over the course of treatment, as she established a better therapeutic, more trust in the therapeutic relationship with her therapist dyad, she did end up changing her preferences for the second dosing session to allow both therapists to provide touch. And of relevance, many of the participants who did have some concerns around the use of touch at baseline, many of them at some point during the baseline interview used the word strangers to describe their therapists. So this person describes this retrospectively. They're talking about how at first they really struggled to understand feeling safe with the strangers in the room, but over time and developing that kind of relationship with them, it did feel helpful. And the first part of this quote being that they felt like the therapeutic touch was more helpful than they would have imagined. And another participant spoke to me about an instance where he was really grateful that his therapist did not provide touch. And at that stage, he was doing some sort of important personal processing of a difficult experience. And we spoke about how the therapist knew not to provide touch in that moment. And he indicated that they may have been attuned to his body language, but that ultimately they didn't know. And the therapy sessions were used to review and reflect on when touch should be used and to refine the ongoing consent process. Perhaps one other element of this theme is that participants did really expect their therapists to be attuned to have a strong therapeutic attunement and to respond to their body language and to read the room with regards to the appropriateness of touch at any given time. So this is a sweeping view of our results. In terms of implications, this is the first participant narrative-based research to support the use of therapeutic touch as a tool in psychedelic-assisted therapy. The findings carry some implications for the consent process. In particular, we would recommend the use of this advanced care directives in protocols that plan to include therapeutic touch. Additionally, I think it is possibly relevant to encourage participants to specify some minimal level of touch that would be appropriate for them. This is based on our finding that participants typically evaluated touch as much more important after the dosing sessions. Although if a participant really did not feel that it was right for them, I think that participant autonomy should always be respected. And in terms of therapist training, perhaps the most practical translation here is the implementation of a debriefing process. I suppose that in some ways we're thinking about touch mirroring the psychedelic treatment process with a preparation and an experience and an integration of that experience. I think that particularly since our trial had a really constrained view to the use of touch, yet we saw this real diversity in the ways that participants interpreted that. Having the opportunity to debrief and discuss this with participants is likely to reduce any potential misunderstandings or misinterpretations that may have arisen, but also to provide really good content for the therapy. So generalizability is not a primary aim for qualitative data, but with our sample size and theoretical underpinnings, we would expect our results to extend beyond the current sample. But notably, populations with generalized anxiety disorder may be predisposed to some dysfunctional attachment styles, and that might have meant that in our sample, touch was evaluated quite positively because it was potentially restorative for these participants. And we should also consider how these results will extend to other psychedelic substances. So, for example, a substance such as DMT, which is relatively short-acting and maybe having a more reliable or complete ego dissolution. Perhaps touch is not so relevant in this situation. We can contrast this with something like MDMA, which has relatively weak hallucinogenic properties, but a much enhanced sensory profile and potentially elevated sexual desire. And conducting research in this space is very important. We will be collecting data on this in our upcoming clinical trial for MDMA-assisted therapy. So I'll skip through all of that and conclude by saying that psychedelic-assisted therapies are rapidly expanding, yet many of the commonly accepted practices are not well tested or evidence-based. I can understand that some people might feel nervous or overwhelmed about the consent process, and this might lead them to either abandon the use of touch altogether or to simply leave it up to therapist discretion. And I hope that this research presents a promising starting point for an alternative approach. Thank you.
Thank you very much, Rachel. We've got a few minutes for questions. Chris.
Thanks. Yeah, thanks, Rachel. So I recently heard someone make the argument that because the use of therapeutic touch is such a minefield, the default should be not to use it unless and until there is quantitative evidence that it makes a difference to clinical outcomes. I wonder what you think about that.
Yeah, I think that it's a really interesting point. I suppose that this is just the start of research that looks at whether it is important for participants, and definitely more research is warranted. I suppose that my view on this front is that in the therapy side of psychedelic-assisted therapy, we scale the therapeutic component right back. So we have very, very skilled therapists who are not conducting the level of therapy in the room that they might otherwise do. And I personally would take a similar approach to touch. I think in this protocol, it's been used extremely minimally. And I think that that is a good approach for the time being. There are some people that think that it might be unethical to not offer therapeutic touch if someone is in that situation and really, really wants it. I don't know that we necessarily have strong evidence in that direction either, but potentially as we analyse some more of these participants, it might emerge.
Anyway, I would just say it like, oh no, I can hear it. So I have some more practical questions. So how do you view the importance of who is initiating the touch? Because I could see that, of course, the standard, what we heard all the time is that the patient should initiate, and that's when we do the touch. But other times I could also see it being helpful if a participant is in a lot of distress and they might not even be able to verbalize or to reach out. So, but I guess that's a very delicate process. So how do you view this?
Yeah, I think it is a very delicate process, and one of our participants actually highlighted this, that it might be impossible to get it right 100% of the time. I think that it's important that these discussions are being had ahead of time and that they're happening after time as well. In our case, the participants were able to change their preferences for the next dosing session. So yeah, it might be that during that first experience, they had a difficult experience and the therapists were not able to suggest to them, would you like a hand to hold? And they can change their preferences for the next one. And we have at least some evidence of someone who maybe did change their mind and wanted more therapeutic touch than they had consented to. And the therapist said, no, we can't provide this. And that person went on to tell us that they felt really safe and respected as a result of that decision. So.
Thanks very much for a really, really interesting, engaging presentation. I really commend you for how you started the presentation by acknowledging that the research was carried out in occupied land. And just as a question, how is your own research influenced, if in some way, by indigenous epistemologies?
By indigenous
Epistemologies, yeah.
I suppose that in this case, the clinical trial itself is occurring under the supervision of my supervisor, Paul Ignaitsky. So I kind of just have this very small pocket. I think that the therapeutic touch component has not been particularly informed by indigenous epistemologies, but this is an area that I'm really interested in, and I'm really glad that this conference will have some speakers addressing this, probably much better than I could.
So thank you very much. We're having a break in this room and we'll be back in half an hour with the topic of the inner healer.